We are live, please.
Yeah, very good evening, everyone. Respected chairpersons, esteemed speakers, senior colleagues, and dear friends and all the participants. It's my pleasure and privilege to welcome you all to this webinar of OSS, Odisha Ophthalmic Society. And this is our first webinar which we are holding. So thank you all for coming together for this, giving your time. So we have choose the topic of retinoblastoma, and it has been designed such to bring together a certain clinical experience. And we know children, they come to us and it's quite difficult to examine them, and we have difficulty in coming to certain clinical diagnosis, making a differential diagnosis. And then also when they come in different stages, then we are also perturbed what next to be done, which imaging and what next to go on, or where to refer them. As we are evolving in ophthalmology, all the diagnostic surgical techniques are also being transformed, and we have with us experts who will be talking on this. And we are indeed fortunate to have national faculties and speakers from India to interact with us today. So on behalf of the organizing team, I extend a heartful welcome to all the speakers, the experts, the panelists, and also to the participants who are joining today. So thank you all once again. So make best use of this program today. So I now request our President, Dr. Sabyasachi sir, to give his welcome address before we proceed with this webinar.
Thanks, Dr. Sucheta, for this webinar on retinoblastoma. I think this is the first under your chairmanship, the Chairman Scientific Committee. So I welcome all the speakers, expert panelists, and also Dr. Ajit Babu Maji, who has been a constant source of inspiration for OSOS and also guiding us. Our other chairpersons also will be joining shortly. And I welcome our expert panelist from outside the state, Chandana Madam, who is also academically very strong and takes interest in all virtual programs, Dr. Bhavna and Dr. Feroz as a speaker. So with this brief welcome address, I request you to carry forward the program.
Thank you, sir, for giving this opportunity. So let me introduce the national faculties. First of all, we have Dr. Chandana Chakravarti, and she's the professor and HOD from JNM Medical College, West Bengal. She was formerly the faculty of RIO Kolkata and consultant in BBI Foundation Kolkata. She has a lot of publications, and she's the IGO section editor for oculoplasty. Welcome you, madam. We have Dr. Bhavna Chawla, who is the professor at this Center, AIMS, New Delhi. She's a great researcher, teacher, and clinician. She has a lot of awards and publications and books. And she has also a book, Global Perspectives in Ocular Oncology. So she has immense depth in this subject. I also welcome our dear Dr. Ajit Babu Maji, a lead consultant of VR services at Yashoda Hospital, Hyderabad. He has served as the president of AIS and VR Society of India and worked at LVP and Center of Sight. But moreover, he is our friend, guide, and philosopher and a mentor for Ophthalmic State Odisha Ophthalmic Society. So welcome you, sir. So now I hand over to Dr. Bigya Panda, so who will be the moderator for this session, and also Mona Lisa Patnaik. Both of them are there. So she will be introducing the speakers and the expert panelist. So over to you, Bigya, to start the session.
You are muted, Bigya. Bigya, you are muted. We can't hear you.
Bigya, you are muted.
Unmute yourself. Yes.
Yes. Am I audible now?
Yes, madam.
So good evening, respected chairpersons, faculty speakers, panelists, and colleagues. So as we all know that every February 15, we celebrate the International Childhood Cancer Day. So today's webinar is a part of our state society's effort to raise awareness about childhood cancers, especially retinoblastoma, which is the most common intraocular malignancy we see as ophthalmologists. So with today's theme, that is retinoblastoma, what all ophthalmologists should be aware of. So today's discussion aims to bring out all the practical knowledge that every ophthalmologist, irrespective of the subspecialty, should be aware of and carry them in their daily practice. We are privileged to have an excellent multidisciplinary panel with us tonight, representing pediatric ophthalmology, comprehensive ophthalmology, retina specialist, oculoplasty and oncology specialist, and pediatric oncologist also with us. So together they represent a complete team who are needed to manage these children. So we are honored to have with us other distinguished panelists. So we have Dr. Pushpa Kumari Madam, who is the Senior Consultant at Jayaprakash Hospital and Research Center, Rourkela. We have Dr. Anuradha Pradhan, who is Oculoplasty Consultant at Carvision Eye Hospital. We have Dr. Aprajita Banerjee, who is Assistant Professor at SCB Medical College, Cuttack. So thank you all for being a part of this important initiative. And with this, I now invite my co-moderator, Dr. Mona Lisa, to introduce our first speaker and begin the scientific session. Over to you, Mona Lisa.
To begin. Good evening, everyone. So today, our first speaker is Dr. Devjyoti Tripathi. He's a distinguished specialist in ophthalmic plastic surgery, orbit, ocular oncology, and right now practicing at MTC campus, LB Prasad Eye Institute, Bhubaneswar. He did his long-term subspecialty fellowship at Urban Eye Hospital, Madurai, and he is trained at Goldschlager Eye Institute at Tel Aviv, the Harshas Medical Center at Jerusalem, and the Jules Steen Eye Institute, Los Angeles, the MD Anderson Cancer Center at Houston, and Jules Gonin Eye Hospital, Lausanne, Switzerland. Currently, he is supervising the retinoblastoma service at his institute. He is the former supervisor of ophthalmology residence program, that is the DNB program at his institute. And today his topic is about recognition and clinical feature of retinoblastoma. Welcome, Dr. Dev. You may proceed with your topic.
Hello, thank you, Mona Lisa. Am I audible?
Yes, sir, you are audible.
Volume is a little less. I think you need to increase the volume.
Okay, is this better?
Slightly.
Yeah, little more louder.
Yeah.
Louder.
Maybe this is better?
Yeah.
Yeah.
Okay. So, thank you, Mona Lisa, for that long and extended introduction. So, my topic today is to sort of introduce retinoblastoma as a disease, and some people here might find this presentation today to be a little basic, but it is mostly intended for the residents and the comprehensive ophthalmologists, as well as the other multidisciplinary faculty who are present here. So I'll just start sharing my screen here. And I hope this is visible.
Yeah, now it is visible.
Okay, so
you need to do something with your volume. It's little lower side.
Okay, so I think
I
I've put it
also
on the
feel
max.
the whole
That's possible.
volume of everyone is slow, or is there any problem with my system? I don't
No,
understand.
no, your volume is good, Vigya.
No, I'm not able
Yeah,
to
Probably you are
hear
controlling
Elise's
well.
voice.
I'll just try to set the volume a little bit.
Can I help
lower.
Dr. Devjyoti?
Yes.
Yeah, please. If you
Just
can.
click on the audio settings in the bottom next to the mic.
Yeah, I did that, and I put the volume.
And when there is a microphone option, just increase it to the max and uncheck the automatically adjust option.
Okay, I'll do that.
You need to stop the share first, please.
Yeah, I'll just do that. I'll get back to the settings, and I'll just.
And audio settings, there is a microphone option. Just increase the microphone option to the maximum. and there is a box which says automatically adjust. Just uncheck that.
I'll do that. Just a moment. Yeah, I've put the
microphone volume, not the
yes.
speaker. The microphone volume to the max. Were you able to find it, doctor?
Yeah. Am I better?
Yes, sir. Much better.
Right.
Yes, yes.
Okay. So I'll go back to sharing my screen now. Right. Is this visible?
Yes. Full screen. Make it full screen.
Yeah, I'm just going into full screen. Just a moment. So this was the topic that I was assigned, and I'm going to speak about what we might term the so-called do not miss features of retinoblastoma. So these help you suspect retinoblastoma and also help you recognize the tumor so that you set in the sequence of early diagnosis, referral, and so on. So retinoblastoma is actually the commonest primary intraocular malignancy in children less than 5 years old. We all know, and it contributes about 2 to 3% of all childhood cancers. But it's not a really very common cancer because it happens only in about 1 in 15,000 to 20,000 live births and about 8,000 to 9,000 cases annually worldwide. Survival rates vary from 30% to 95% plus depending on where you live in the world, and it is highly curable. So the question is that if it is not such a common cancer, then why are we talking about it today? And let's have a look at why we think it's an important disease to talk about. So as you people can see this, So this is a map which shows income levels across the globe and incidence of retinoblastoma and the centers that are available to treat it worldwide. Now you can see the shades of blue are signifying the incidence of the disease. The darker the shade, the higher the incidence. And if you can look at the whole map, the darkest shade is India. Apart from that, we also see that the treatment centers across the globe have about 3 concentrated regions broadly. One is here along the eastern coast of the United States. One is here in Europe, Central and Western Europe mostly, and the other is here along the eastern coast of China. If you look at India, then the treatment centers, the number of red dots that you see here are very few. And compared to that, look at this statistic. This is the disease burden across different countries in the world. And if you look at United States, where we just saw that there is a large concentration of treating centers along the East Coast, the number is 252 compared to 1486 in India. So we have literally 6 times the burden of disease as compared to the United States, and we are not well equipped to handle this disease burden as of now. So retinoblastoma is a tumor which arises from the primitive retinal cells, which are the cone photoreceptor precursors within the inner nuclear layer of the retina, and can be broadly divided into heritable and non-heritable disease in terms of types. I'm not going to go into the details of genetics as Fairuz is going to talk about it later on. But we need to know that in heritable retinoblastoma, there are other non-ocular cancers that can happen in the patients, and the incidence increases with the follow-up. So these patients have to be followed up for life, and it is very important to understand that one has to watch out for a possible second primary cancer that can occur in these patients later on in the course of their lifetime. So leukocoria, as we all know, is the sine qua non of retinoblastoma, the white reflex, which you see in this child here, and it can present in different ways. This particular chalky white appearance that you see here because of the calcification that happens within the tumor because of tumor necrosis is something that is very, very typical and is very crucial for suspecting the diagnosis of this particular tumor in the eye. There are signs other than leukocoria which can present to us. They are not as common. Strabismus that you see in this child is the second most common. In fact, you actually see a leukocoria plus a strabismus in this child. But there are other presentations which may be seen in children like anterior chamber tumor deposits, which you can see in terms of bulky masses here or greasy seeds here. There can be something like a tumor hypopion that you can see here, or sometimes the disease can present as an aseptic orbital cellulitis. There are certain atypical presentations which can present as other diseases and confuse us, and herein lies the challenge of suspecting retinoblastoma. We just saw that it can present as orbital cellulitis, and this is another example where it presents like something that looks like an lid abscess with tense edema. But imaging shows you that there is a calcified mass that is located intraocularly and there is severe periocular and orbital inflammation. So this is another variation of an atypical presentation of an aseptic orbital cellulitis that can happen with retinoblastoma. This is another variation of the atypical presentation. This child was suspected to have panophthalmitis clinically when he first presented to the OPD, and on imaging it was evident that there was an intraocular tumor. There is a big chunk of calcification that shows up in the imaging. This child was suspected to have uveitis when he was first seen in the OPD, and I think it may not be very clear, but if you look at the anterior chamber here, you will see a very fine dispersed dust-like floating cellular material inside the anterior chamber. And when this child was taken up for an EUA, what we saw was a total retinal detachment with a big tumor that was located in the subretinal space. So these are the cases where retinoblastoma presents in the patient with signs and symptoms which are not what we classically talk of as in leukocoria. This child came in with a suspected mass lesion that was diagnosed somewhere else, but when this child was seen, if you can notice here, the child has a red reflex in this eye, but this red reflex was a little dull compared to the other eye. I don't think the other eye reflex is seen well in this photograph, and there was something suspicious. So when we went in and did an imaging, what we found was that there was a tumor inside and it had spread all along the optic nerve posteriorly with a significant thickening of the nerve that was very evident on imaging. So one of the well-known journals of oncology way back in 2011 published an article which was titled as this: leukocoria, all that's white is not retinoblastoma. For sure, all that's white is not retinoblastoma. So let us have a look at what all can be white but is not retinoblastoma. Here comes the differential diagnosis of the common conditions that can mimic retinoblastoma: Coats retinopathy, congenital cataract, retinopathy of prematurity, hyperplastic primary vitreous, toxocariasis, and the others like retinal dysplasia and incontinentia pigmenti, which are not as common as the ones that we mentioned just now. So how do we differentiate between these? Coats retinopathy typically has a yellowish reflex compared to the kind of reflex that you find in retinoblastoma, which is comparatively whiter. and often the reflex in Coats retinopathy is called as xanthochoria instead of leukochoria. So even though you see that there is an exudative retinal detachment in these cases, both of these cases, and they look similar to each other, the reflex in this is distinctly yellow compared to the kind of reflex that you see in this particular case. And if you look into the eye, you will see that Coats retinopathy is essentially a subretinal disease. If you see, the exudates are all subretinal below the vessels, and you find these typical vessels which are telangiectatic and bulb on end appearance, and this kind of granular deposits at the edges of the detached retina where the exudative detachment is seen. Apart from this, Coats retinopathy does not involve the vitreous. It's essentially a subretinal exudative retinopathy. Whereas in retinoblastoma, you can see that the tumor can have a mixed component. You can see a retinal fold here from the retinal detachment, and you can see on either side the tumor on either side of the fold. So there is a component which is subretinal, and there is a component which is in the vitreous. So a mixed pattern, exophytic and endophytic tumor. Sometimes retinoblastoma can be flat, only subretinal, and can very closely mimic Coats disease. But even in this case, you can see this one particular calcified part of the tumor that is projecting into the vitreous. So these are some of the differences that.
Vijayati,
Yes, sir.
am I audible? Yeah.
Yes,
This
please.
picture typically is because of the chemotherapy. Post chemotherapy, most of the retinoblastomas present with calcification. So this is one of those. Definitely, this child must have had chemotherapy.
Yes, this child has had chemotherapy. But in some of the children, sir, even at presentation, the calcification can be seen very much.
Yeah, but not this much, very less. And there can be two types of regression. One is calcification, second is flesh.
Agreed. But in some children, you see a lot of calcification right at the start, like in this child. This is the first UA. The photograph that you see here is at presentation.
Yeah.
And it was chalky white calcification.
One thing is sure that if any calcification on B scan or CT scan, retinoblastoma can be a high possibility.
True. So these are some of the differences that one sees between Coats retinopathy and retinoblastoma. How do you differentiate it from congenital cataract? So this is how congenital cataract typically looks. Sometimes it will have this little bluish hue, and sometimes it will have this little stuck-on appearance. And I don't think it's very evident in these photographs, but if you carefully see the child, you will see that this opacity is actually located in the lens, which actually is much anterior to what you see in retinoblastoma. Now in these two, you can clearly see, if you notice closely, that the lens is clear, and the mass that you see is actually intraocular, deep inside the eye. The color is also different. It's a off dirty white color, and in this particular patient, you can actually see a couple of seeds there. So this is one way of differentiating clinically, and of course, you can go on to have ultrasound confirmation of the calcification and the other characteristics of the tumor that typically show up as an intraocular mass, which will not be there in congenital cataract. The other differential that we come across is retinopathy of prematurity, which can present like this. The reflexes can have complicated cataracts, and one of the typical features that you have in retinopathy of prematurity is this tractional band which goes from the disc to the temporal retina. And here again, if we have an ultrasound available, then we can see that the typical detachment that we see in the retinopathies of prematurity is here represented in these two pictures in the lower panel, whereas in retinoblastoma, you actually see a solid intraocular mass. Primary hyperplastic vitreous, which is persistent, can also present as white reflex in the pupil, which you can see here, the arrow it's obscured by the corneal scarring here, but you can just make out here at the edge that there is a white reflex in the pupillary area. This is the typical tube-like appearance of the persistent vascular structure that you have on ultrasound, and this is of course very different from the kind of mass lesion and intraocular calcification that you get to see with retinoblastoma. So retinoblastoma can be intraocular. As we all know, it is divided into 5 different groups, A, B, C, D, E, with progressively increasing size and extent within the eye. And to just simplify it, here are the 5 groups. And this red line that we see in the middle is an important dividing line between the groups that are essentially within the retina or essentially intraretinal, with the groups which have disease that goes into the vitreous or into the other structures in the eye. So if you follow this arrow upwards, you get prognosis which is better, and you have much higher chances of salvaging the eye. And if you follow this arrow downwards, you have prognosis which is worse, and globe salvage that becomes progressively more and more difficult. But the disease can become extraocular, and we do have a staging system for this too, with stage 0, 1, 2, 3 and 4 denoting progressively extensive disease and higher stages with worsening prognosis along that stage. So when there is overt extraocular disease that is present outside the eye within the orbit, but there is no locoregional nodal or systemic metastasis, we stage it as 3A. When you have extraocular disease along with nodal metastasis, as you can see here, we stage it as 3B. And when it goes beyond that, when you have overt extraocular disease with local extension and node involvement, which you can see here in this child, along with bone marrow metastasis, that is distant hematogenous metastasis, that's staged as 4A. And further, if there is involvement of the CSF, then it is staged as 4B. So you can see this extension along the optic nerve with this nodular, bulbous nodular growth, and this particular, and this is a post-treatment photograph, I mean a post-treatment image. This is what can give rise to CSF metastasis, which is actually the highest stage with very poor prognosis. So awareness for this tumor is actually the key, and this leads to early detection, referral and intervention. So this is a very necessary and critical loop that we need to close, and only when we close this loop can we hope for early intervention, good outcomes, higher possibility of globe salvage, less chances of extraocular extension of disease, less chances of metastatic disease, and overall better outcomes in terms of globe salvage as well as in overall patient survival. Because if we don't do this, then this is something that can happen. This child came into us first time in 2010, October 2010, if you can see that on the image. And this was the kind of disease that the child had. So this child was actually advised for enucleation, and the family was unwilling and went away. And child was lost to follow-up, came back 1 year later. And this was in October 2011. And this is what had happened. So this is what can happen when there is delay in intervention. And we can end up with advanced local disease. We can end up with extraocular spread, which can be regional or systemic metastasis. And eventually we end up with poor treatment outcomes or death. So this is what we don't want to see. So We come back to the good old journal, which says that leukocoria, all that's white, is not retinoblastoma. But since in India we have such a high disease burden compared to the other parts of the world, it would be well for us to start with the assumption that all that's white is retinoblastoma and then investigate the patient further before we decide that it's not. Let's remember the cat and its eye and the reflex. That takes us a long way in recognizing this disease early. Thank you.
Thank you, Dr. Dev, for this elaborative lecture. So my first question is what are the red flags that will helpful to distinguish retinoblastoma from a true inflammatory uveitis?
Red flags to distinguish retinoblastoma from a true inflammatory uveitis.
Yes, because it can masquerade as retinoblastoma can masquerade as uveitis, right?
Well, retinoblastoma masquerading as just uveitis is not very common.
Okay.
It can masquerade as an inflamed eye, which will have signs of inflammation in and around the periocular region. Because what essentially happens is that the tumor undergoes sudden massive necrosis, and there is a reactive aseptic cellulitic response that happens because of this necrosis. So many times you will find it manifesting as inflammatory signs that are seen in and around the eye, like we saw in those children who had swollen eyelids and tense edema. But only uveitis is not very common. The only case that I probably showed was that the one with the flaky dot-like deposits floating around in the anterior chamber. That was the only child I think we suspected uveitis in. But otherwise, I don't think only uveitis is a very common presentation that will confuse you with retinoblastoma. Maybe you will think of other things that can be happening inside the eye if you have uveitis in a very young child.
Ladies want to ask, tell something.
Yeah. Hi, Dr. Devjyoti. Excellent.
Hi.
Yeah, what you have said is right, that you will
Wonderful.
see the pulse appearance in the antechamber, which are white, and the synechiae are very, very less in case of retinoblastoma, whereas synechiae are more prominent in case of uveitis. And the antechamber cells will be there, intervening areas. Antechamber cells and flare will be there in uveitis, whereas in retinoblastoma, it's missing.
Dr. Anuradha, you asked the question, right?
Dr. Mona
Dr.
Lisa.
Mona Lisa
Mona
asked
Lisa.
the question. Yeah, right. Yeah.
They-
Yeah, very valid question. And as Devjyoti, Dr. Devjyoti correctly explained, there are times where it can masquerade as uveitis, not as that, red painful uveitis, which is obviously, due to the necrosis. But in older children in retinoblastoma, they can present with anterior segment seeds, which can actually, kind of masquerade as uveitis, like, in older children, where you have only these seeds floating around. And there is also an entity called anterior segment infiltrating retinoblastoma, where you will have no evidence of retinoblastoma in the posterior pole, and it will be only in the anterior segment. Sometimes you can find a small nodule sitting in somewhere in the angle. Another masquerade, and as Dr. Ajit Babu mentioned, you will not have any other features of uveitis. There will not be synechiae which will be present. It's basically those seeds sitting in the ciliary body and in the periphery, which jumps into the anterior chamber, and then it floats around. Now, this Dr. Ajit Babu will be able to answer. There are situations, again in older children, they can present like a vitritis. Most often the retinal surgeons get confused between endophthalmitis and retinoblastoma, but the vitreous seeds in retinoblastoma is very, very classical. And if you really look into the periphery or aura, there will be some foci of RB sitting in there. And I'm sure Dr. Ajit Babu will have experience with this, where, older children might be coming in where you have a confusion between an endophthalmitis vitritis or a retinoblastoma vitritis. And these children undergo vitreous surgeries as well. So, your insight on this?
Actually, if you see diffuse retinoblastoma types, means Santosh and myself shared a lot of cases. So
Right.
diffuse type of retinoblastomas usually present this kind of presentations, what Mona Lisa has asked. But proper, it's not endophthalmitis exactly, but it is a pars planitis with lot of exudates inferiorly, which can mimic retinoblastoma in a localized area for retinoblastoma, where if you see the exudates inferiorly, it will be more hazy. It's not clear. And the vitreous, definitely vitritis will be there. Absence of vitritis with only exudates probably certain times should raise the alarm of the retinoblastoma, because certain times the diffuse retinoblastoma types may not be extensive. Those cases you may mistake it as a vitritis and then intervention and extraocular extension. That is the most dangerous thing that can happen.
Yeah, so mostly it is the endophytic variant where
Phytic,
the
yeah.
vitreous disease, yeah. Which, and in older children, in younger children, you're almost sure that this is going to be retinoblastoma. But when an older child presents with vitreous features, and mostly in older children, as the child grows up, the appearance of retinoblastoma is towards the periphery. The younger
Yes.
the baby, it will be in the posterior pole. And as the child grows, the age is more and more, actually the retinoblastoma keeps appearing in the periphery. And that is, due to the development of the retina, the centripetal and the centrifugal development of the retinal cells. Yeah.
I just have to add that some of these older children can present as pseudohypopyon. That
Yes.
sometimes, yeah, it is the thing. And then we have a confusion in this.
Yeah.
I just want to ask
Pseudohypopyon only I was mentioning
Yeah.
that
Yeah.
it will be pearly appearance, pearly white
Yeah.
appearance. It is not like
Yeah.
a yellowish
Yellowish
thing, and
appearance, yeah.
these pearly white you will be discrete.
Yeah.
High mag,
Yes.
you need to have the examination, otherwise you will miss it certain time.
I have one more question for the panelist. What about this vitreous seeds? So can you just describe about it? So we have read about that it is dust-like, spherical and all. And what is its significance? So Bhavna, Dr. Bhavna, you can take this question.
Yeah, I can certainly take this question. So, yeah, vitreous seeds are supposed to be most difficult to treat, and that is why, group D retinoblastoma becomes challenging because there are diffuse seeds, and in fact, D can be again, associated with subretinal seeds or vitreous seeds. But when it comes to vitreous seeds, that is more challenging. And so there is a classification of vitreous seeds. Dr. Francis Munier has done a lot of work on that. And they can be, like you mentioned, describe different types, the dust, the spheres, and the clouds, and they are prognostically different. The good thing about vitreous seeds is that earlier, whenever we used to talk of globe salvage treatments, we used to have intravenous chemotherapy. And then came the era of intraarterial chemotherapy, which again worked quite well on the tumor masses, but it was the seeds that, still remained a challenge. But ever since, intravitreal chemotherapy has been introduced, and especially with, the safety enhanced technique that we use now, it is like a more and more universally acceptable form of treatment, especially designed to treat the, chemo-resistant vitreous seeds. And for that, nowadays, we initially started with the melphalan drug, but now, over a period of time where, there have been cases, and we have also seen in our personal experience that, especially the Asian eyes, the darkly pigmented eyes, they tend to show some toxicity to intravitreal melphalan. So now we are switching more and more in favor of topotecan. So we give these multiple intravitreal injections at defined intervals, and every time we do an EUA to see the response. And initially, the dose of topotecan was also a little on the lower side, but now that we're getting good results, people are going on to more and more high dose topotecan, and that seems to be working quite well as far as vitreous seeds is concerned. So after intravenous chemotherapy, for the remaining vitreous seeds, we can use intravitreal chemotherapy. Sometimes we also use it, like at AIMS, we use it in combination with intraarterial chemotherapy, where we really want to salvage the eye. And we feel that, because nowadays more and more eyes are being salvaged, unlike the past, the eyes that, would otherwise be treated with an upfront enucleation. Now we're trying to preserve those eyes and try to save vision. So intravitreal
Dr. Bhavna,
chemotherapy, yeah.
how much is the dose you use topotecan
Yeah,
intravitreal?
so earlier we'd started with 20 to 30 micrograms initially, and we used to give 3 weekly injections. But now we are, we can safely go up to 80, 100. In fact, in the literature, people have gone even beyond that. So, a higher dose topotecan is also considered safe and effective in treatment of vitreous seeds. So,
thank you.
yeah.
Actually, so we can go ahead for the next talk, and then we can have a
Yes, ma'am.
discussion on it. So
Thank you, Dev sir,
Sure.
for your excellent and very practical talk. We'll definitely keep in mind the practical points you have suggested. So we'll move on to our next speaker, Dr. Feroz. She is a specialist in oculoplasty, ocular oncology, and founder director of Horus Specialty Eye Care, Bengaluru. And as we all know, she is a wonderful speaker, and she keeps all. She can make any complex topic easy, and so we hope her talk is gives us a very practical understanding, and we'll learn much from this. So over to you, ma'am. She'll
Thank
be speaking on all about genetic testing and all about management of retinoblastoma. Over to you, ma'am.
Thank you, Bitna. Thank you, Dr. Sucheta, for having me here, and the entire Orissa Ophthalmological Society for having me here, and respected panelists. Bitna, am I covering the classification as we discussed, or just the genetics?
I think the genetics and the management.
Management. Okay, I'll stop there. Fine. Yeah. I'm going to share this slide here. Okay, so I will not be talking about the classification. I think there was a miscommunication. Right. These are my acknowledgements. As far as retinoblastoma is concerned, I really want to acknowledge my team. It's just not me who is treating these retinoblastoma patients. It is an entire village which takes part in the management of these kids. And geneticist also plays a major role, apart from the pediatric oncologist, the interventional neuroradiologist, the radiotherapist, the pathologist, and even an ocularist. And these are my affiliation, and these are the foundation which often helps my patient in accessible and affordable patient care in retinoblastoma. Thanks to all and all the parents and the patients. So retinoblastoma has taught the world how actually cancer begins with the discovery of the retinoblastoma tumor suppressor gene. And what I want to really highlight here today is that retinoblastoma is a genetic disease, and that should be really, really well thought in order to identify the disease, the prognosis, and long-term survival of these patients. To be brief. Now, the etiology of retinoblastoma, we all know that it's due to genetic mutations of the RB1 tumor suppressor gene at the chromosome 13q14, and MYC amplification is also identified. And a very complex association is a mosaicism in retinoblastoma, which can also cause mutations. Now, I'll start with a short story over here. I would say that retinoblastoma, every child with retinoblastoma starts with two stories. One is in the eye, and, the other one is actually in the DNA, and that is the 13 chromosome. So this is daddy who has been enucleated, who is blind, who has been radiated in the 80s. And so everyone in his family, including his two brothers, his mother and father, actually knows that he has a retinoblastoma. But little did they know that he can pass these genes. One second. Little did they know that he can pass these genes to his child. So when, and the father cannot see, the father didn't identify any symptom in this child. The mother who got married into the family also didn't have any idea that, the child can have retinoblastoma. But when it was alarming for the family when they found that this child was having squinting and a white reflex in the eye, and there was a panic call. The father's younger brother called, tried to reach out and tell that, we are finding a white reflex in the eye, and we have been referred from a doctor suspecting a tumor in the child. So what we need to identify here is that whenever there is a disease, it's a genetic disease, a family pedigree is very, very important. And there is a 50% chance that a patient with retinoblastoma can, pass on to the disease, 50% chance of this disease being passed on to the offspring, and also siblings can have retinoblastoma. Even this child has a 50% chance of passing the disease to his child. So there are three things that we learned from this particular story: that this is a familial RB, the baby got the disease from the father, this is autosomal dominant with 90% penetrance, the child had bilateral retinoblastoma from the father, and the third thing is that it is a germline mutation which has occurred while the child was in the womb, and this has been passed through the sperm of the father. So we don't stop here. When we form a pedigree, we actually go back. We just go back and trace what's been happening in the family. So we traced the family pedigree. What we found was that the father's father, in the paternal side, his brother's child had died, was blind and died in childhood, but they never knew what the diagnosis was. So basically, there was a low penetrance of RB which is existing in this family, which has passed on to generation, and this baby presented with retinoblastoma. Another thing that we learned from this particular case regarding genetics, heritable retinoblastoma and familial retinoblastoma, is that it's usually present at birth, it's usually bilateral, and it is multifocal. And this is exactly the fundus of this baby: bilateral tumors, multifocal tumors in both the right eye and the left eye. Well, fortunately, as Dr. Bhavna has mentioned, the management of retinoblastoma has evolved to a certain extent that we are able to salvage more eyes. And fortunately, this baby did not land up like his father, losing the eye, being enucleated or radiated. We could save both of his eyes. But if this family would have known that retinoblastoma was a genetic disease, we could have given a better vision to this child, where the child would have been screened as early as the child is born, and then we could have treated it better, and the prognosis would have been a different story in this case. Now, we have children presenting with unilateral retinoblastoma, and these are non-heritable, and these are associated with somatic mutation. Still, there is a genetic mutation happening over there. Usually, these cases happens in infancy and above. It's usually unilateral, unifocal, and solitary, as in this case. He doesn't have a family history of retinoblastoma, and in his genetic testing, there is no retinoblastoma gene mutation which has been proven to be mutated. So thanks to Knudson's two-hit hypothesis, this gave a lot of insight into the RB, where we always know there only when one brake falls, the car doesn't stop, or there is no accident. So there has to be two brakes. When both the brakes fall, that's when the accident happened. And this is exactly what Knudson's two-hit hypothesis means. When it comes to heritable germline mutation, the first hit is in the germline. It could be the father's sperm, the mother's egg. It could be while the zygote, mutation happening at that point of time. So the first hit happens there, and then the second hit happens in the developing retina. And then you have the RB development. Now, initially it would be retinoma, and then there are also known certain genetic and epigenetic events that can lead to the development of retinoblastoma. So, for example, if it is a heritable germline mutation, it's not necessary that always it could be bilateral. 20% of unilateral disease can also have germline mutation. So basically, they have RB1 mutation happening cells in the eyes as also in the blood and in the body. For the same reason, they have the risk of second cancers in heritable germline mutation. So these are the risks. In a non-heritable somatic mutation, what happens is that both the hits are happening in the developing retina. Still, there are two hits that is happening in the gene, and then because of that, they usually present at a later age. It's unilateral and mostly monofocal. These patients doesn't have the risk of retinoblastoma in the offspring or the siblings, and they don't have risk of second cancers. Another entity that we need to know is, as far as the germline mutation or the heritable retinoblastoma is concerned, is the trilateral retinoblastoma, where the child can have both bilateral retinoblastoma as well as a pinealoblastoma, and this is called trilateral. Now, there are very, very, very rare situations. They can have a suprasellar tumor also, along with the pineal gland involvement, and that is called quadrilateral retinoblastoma. Very rare, in fact. I just wanted to mention it over here. Now, there are certain syndromic association with retinoblastoma associated with, genetic mutation, and this is the 13q deletion syndrome. Pretty rare, I would say 3% of patients can present with 13q deletion syndrome, where this child actually has bilateral retinoblastoma. His left eye has undergone, it's actually thicical. It was a large tumor with extraocular extension. It has undergone necrosis and it looks thicical. And he, in fact, has intracranial extension, but still the baby looks very, very cheerful. And once a child with retinoblastoma has a particular facial features, you should always rule out 13q deletion syndrome. A genetic testing was done for this baby, and it has been proven that with all these facial features, I'm not going into the detail, you can see the picture here and I've put the list of it, that he had a 13q deletion syndrome. So what RB genetics again has told us, it's just not knowing about the genes and how the disease happens, about the etiology and pathophysiology, but actually it's a warning sign and it's a screening tool. So we should know that if there is a disease which is existing in the family, the child has to be examined as early as the baby is born, and this education and counseling has to be done to the parents, and it's in fact a very good screening tool. Now, this picture is when the child was born, and the child was in my hand when he was like, I think 3 weeks old. But this is a very interesting case where, a child was detected to have retinoblastoma in the womb of the mother at 38 weeks. And then, the pregnancy was induced. This is the ultrasound immediately after birth, where there is a tumor sitting in the left eye. And in fact, there is a small tumor in the right eye, which is not detected by ultrasound. And this is how the eye was at the time of birth in this child. And this has been reported. And why it has been reported? For a different reason, because this was the youngest baby that I had treated with intraarterial chemotherapy in one eye. And that's the left eye. As you can see here, at 14 weeks of age, we prepared, and right eye was treated with a laser. Now, going on to the genetic screening of retinoblastoma, as early as the baby is born, we screen them. Maybe in the womb, if you know that there is a history, you can tell the gynecologist or the radiologist to keep a watch from 36 weeks. But much, much more earlier, we can find out a retinoblastoma with chorionic villus sampling at 10 to 12 weeks gestation, and amniocentesis a little bit later at 15 to 18 weeks. Much, much more earlier, what we can do is the pre-implantation genetic testing, which is called PGT, where it is used as an IVF, where a healthy sperm is selected, a healthy egg is selected from the mother, which doesn't carry the mutation, and then it is implanted and an IVF is done. So this is how a genetic testing in retinoblastoma really helps in prevention of the disease. So genetic counseling and long-term survival is very important in these patients. As I already told you, this is a similar story where we failed, where the father actually had retinoblastoma. He had no idea that this can be passed on to his child. Child presented with bilateral retinoblastoma. I couldn't save the left eye, I saved the right eye, but well, there is a stark difference, and this actually shows the evolution of management of retinoblastoma, where we have come from, where father has no eyes, radiated, deformed face, but this baby has a prosthetic eye sitting in there. So what we need to know is genetic counseling is very, very, very important. Knowing the percentages, how much this can be transmitted to different whether it's an offspring or a sibling, and then keep a watch over these patients, just not transmitting the disease, but also for long-term surveillance, because germline mutation and heritable retinoblastoma can have second cancers, in the later life. Now, genetic advances of retinoblastoma in a nutshell, there is a lot of study going on. Well, we have not reached much into in practice clinically with the researches that we have done. There are pathways which has been identified, there have been particles which has been identified, gene therapy is underway, but it's all in the experimental phase. So yeah, I'll stop here. I'm not gonna go with the classification. Yeah.
Yeah, thank you, ma'am, for explaining such nicely in a very interesting manner.
Yeah. Can I just show one thing here? When
Yes,
you
ma'am.
spoke about the uveitis, one case, this is the classification, yeah. So this was a child who was actually thought to have uveitis until this small tumor grew in the anterior chamber. An older child, 5 years of age, the posterior segment, this was what I was mentioning about diffuse anterior segment RB. Yeah. Yeah, done.
So, ma'am, should we take the questions now, or after you finish your second
Let her
topic?
finish. Yeah. We can discuss.
Ma'am, you can continue with your second topic.
Second topic, yeah, sure. I hope it's not too long and you're not feeling bored. Okay. So Bhavna has already given an outline of a few things that I'm going to talk about here. The good news is, the outcome of retinoblastoma has drastically changed from how it was 1 decade back with the introduction of new modalities of treatment. Well, the time-tested and excellent modality is systemic chemotherapy, but then we have intraarterial chemotherapy, intravitreal chemotherapy, intracameral chemotherapy, plaque brachytherapy, and various other adjuvant techniques. So starting from the slide where I have left. So basically, this is the evolution, and now it's just not for sight, it is for, smiles and second chances for these retinoblastoma patients. What is very, very fascinating about this childhood cancer is that this is a curable eye cancer. This is one of the most curable eye cancer in childhood, and it's almost more than 98%. Well, the prognosis is better if it is earlier detected. I'll take you through a few stories over here. This is a 10-year-old boy, exactly how I was talking to you earlier regarding how these tumor presents in older age group. He had bilateral retinoblastoma, bilateral hypopaeon. He came to me as this, as you can see in the corner. The left eye is thusical, no vision, pre-thusical almost, cataract, you can see the yellowness there. And this eye had hypopaeon. It's not too visible over here, but this is how he presented. And he was advised bilateral enucleation. So that's how he got referred to me, at least to save his right eye. So this is posterior pole because he has already got treated elsewhere. There's a laser being done in the right eye, parafoveal over here, temporal, superior temporal. Peripheral lasers done. Nothing seen, everything is silent, clear. But what you see here is the ciliary body deficit. So when you have an anterior segment RB, it's actually very, very challenging because all these seeds, like, tooth-like seeds sit in the ciliary body at different location and sometimes very, very diffuse, as in this case, and this comes to the anterior chamber. Pretty challenging. And this was how I received this child in my hand. So what we did was in the right eye, we gave intravitreal topotecan injection. This is the dosage that I use in my practice. I very rarely go for a higher dosage. 3 intracameral topotecan injections was given, and focal peripheral cryotherapy was done, very focal in certain ciliary body area. And the left eye enucleation was also done, and he received systemic chemotherapy 4 new cycles. Now, I'll just take you through how we do an intravitreal chemotherapy since Bhavna spoke about it. This is how we do it. It's not tough. It has to be safety enhanced. You have to be very, very careful. This is like any injections that you give for retina, anti-VEGF injection, pars plana, 32 gauge needle. But there is something very important in giving these injection into an eye with retinoblastoma is that there is a possibility of a tumor seeding coming out when you withdraw your needle. So you do cryotherapy at the site of injection. You freeze the needle and then only you withdraw. So this is triple freeze thaw cryotherapy. This is 1 cryo, and then after that thaws, freeze and thaws, then you give the second cryo, and then after that freeze and thaws, you give the third cryo. After that, that's the third cryo. I'm just gonna skip it. Yeah. And then you kind of jiggle the eye so that the topotecan injection really diffuses everywhere in the vitreous seeds, because sometimes you can have just not focal but diffuse vitreous seeds. And make sure that you inject in a clock hour, which is very much 3 millimeters, at least 3 clock hours away from the area of vitreous seeds. And then you wash it very well with the saline, apply an ointment, and then you patch it. So apart from this, the ciliary body, inferior ciliary body tumor, he also received plaque brachytherapy because it was tough with cryotherapy and injections alone. And finally, we could save his eye, and this is how he finally looked like. Now, with the radiation, with the injections, he developed cataract. We still didn't give up. He underwent cataract surgery, and there is particular way of doing cataract surgery in these kids. It's a clear corneal incision. We never go make a tunnel in the sclera because you have to be very, very careful and have excellent surgeons working with me. This is Dr. Praveen Murthy, who did a cataract surgery, and with all the cryos he had Sinake and stuff. So that was also taken care. Well, the tumor did, the story didn't end there. So in October 2022, he came again. It was his EUA. He was having good vision after all these things. We saved that eye. He had a scar over the brow, and the visual was PL positive, and that too inaccurate. And the child was crying, and he said, "You know what? I cannot see anything. I just touched the eyes, and it was a soft eyeball." Now, what happened was, while he was playing with the gilli danda, there was a trauma to his eyes and he developed a total retinal detachment. This was a bummer for me because we took so much of care. We wanted, to save the eye, and this came as a shock and a surprise for us. Well, we still didn't give up. Dr. Krishna went ahead doing a retinal detachment surgery for the patient. Dr. Ajit Babu is here, and he's an expert in this with Dr. Santosh Unava. I'm sure he has done the maximum number of cases. So we did a retinal detachment surgery for him. This is how his retina was detached, and that was kept in place. And then finally, we got him with the best corrected visual acuity of 6/24. an intraocular pressure of 10 millimeters of mercury, and a stable retinoblastoma. So this is how certain journey of retinoblastoma really takes us through. But with the modern, treatment and advances in the treatment, we are almost able to, overcome certain challenges that we face, and, great surgeons, great equipments that we have. So finally, this is June 2025. He has become taller than me. He's doing well in his school, and his visual acuity is stable at 6/24. This is the recent picture that we took, and he's doing really well. This was a 13-year-old male I saw in 2016. At 2 years of his age, when it was 2005, his right eye was enucleated, and he was given systemic chemotherapy to save his left eye, but he had allergy to the systemic chemotherapeutic drugs, and then the left eye was given radiotherapy. And many, many years later, when he was 13-year-old, he was on regular follow-up. One of his yearly follow-up, he came with this lots of vitreous seeds in the only one left eye that he has, and there is one small tumor foci here. Now the dilemma is, obviously I don't want to put him through systemic chemotherapy. I don't want to give him radiotherapy, and what I had at that point of time was intravitreal topotecan, and this was how his eye was. I gave him 4 injections of topotecan, and this entire thing cleared up. And I had to give a little bit of laser to that tumor over there. And this is how big he is. And I'm so proud of him, and he's doing so very well. This was his last follow-up 3 months back. So eye preservation treatment strategies in retinoblastoma, as I told you, we are fortunate enough to have all these treatment techniques which is available in India. And I believe that we are in par with Western standards with the equipments and the treatment and the training and the specialists that we have in India. And well, we also have a gift from the Baba Atomic Research Center now, that we have an India-made plaque brachytherapy, which has brought down the cost of plaque brachytherapy, which was initially imported from Germany, Baybic, which was 18 to 20 lakhs, now to 55,000, which is available in India. And that is also a boon. So we are actually in a very, very good place. So the outcome of intraocular retinoblastoma with systemic intravenous chemotherapy has been excellent. And I would say majority of my patients still receive systemic intravenous chemotherapy, and very minority of the group of patients receive intraarterial chemotherapy. As Dr. Devjyoti said, A, B, and C has excellent outcome with treatment modalities, but where we kind of face challenge is the group D and obviously the group E eyes. But with intravitreal chemotherapy, all these dense vitreous seeds we are able to treat now. So this is a patient, unilateral girl child presented. There is absolutely no visibility of the fundus, advised enucleation, referred, and this is how she responded. So she got a systemic chemotherapy, periocular topotecan at this point I gave her. Then after the seeds kind of reduced, I switched to intravitreal topotecan, 6 cycles. She received plaque brachytherapy for this inferior ciliary body lesion. And this is how her whole entire retina cleared. And this is the peripheral tumor, which completely calcified. And she actually has a vision of 6/6 with an absolute clear, healthy fovea over here. And this eye has been saved, and she's on follow-up for the past 10 years. Group D retinoblastoma, as Bhavna really highlighted, that it is challenging. We were struggling to save these eyes many years back. And in fact, my first paper publication on retinoblastoma was management of vitreous seeds. And at that point, we used periocular carboplatin and radiotherapy and systemic chemotherapy. This was way back when I was doing my fellowship, but things have changed now. This is systemic chemotherapy, 6 cycles, periocular topotecan. So you asked about the classification of seeds. This is exactly all the classification are here, Dr. Bignya and Dr. Sacheta. This is the spherules. This is the dusting that you see, and this is the cloud that you see over here. So this child was treated. The other eye was enucleated because it was ophthalmos, and this was the only eye that was salvageable, and the eye was salvaged in this case. Now, intra-arterial chemotherapy versus systemic chemotherapy. Intra-arterial technique is where you target the chemotherapeutic agents directly into the ophthalmic artery through a catheter which gets introduced through the femoral artery, the aorta, the internal carotid artery. And what is fascinating about this particular technique, it is an advance in the treatment of retinoblastoma, is that we're able to salvage the DIs better than systemic intravenous chemotherapy. And this is my work with Dr. Shields and my China group, where, when you compare the chemo reduction, salvage is 47% when compared to IAC, or the group DI salvage is almost 85% to 94%, as in here. So these are the results of intra-arterial chemotherapy. This is a child with a group D. All these are diffuse seeds that you see here. And intra-arterial chemotherapy, 4-session intravitreal topotecan, and all the seeds have calcified, and then the entire tumor has calcified. Sometimes, very rarely, there are situations when there is no risk for the child. Group EIs also we salvage when there is no risk to life, and this is a case similar, systemic chemotherapy, cryotherapy, and transpupillary thermotherapy, where the group EI has been saved. Another case of group EI, where, when the optic nerve is okay after MRI and the patients are really insisting on intraarterial chemotherapy, we go ahead. And this is an intraarterial chemotherapy, 4 sessions, and intravitreal topotecan 3-session, and the eye has been saved. This is the same case that I showed you, only the anterior segment, and it's a salvageable eye, but lots of paracentesis has been done to rule out PCR, various viral uveitis, etc. And finally this tiny tumor started popping up in the angle. It's not I have seen this case along with my mentor Dr. Shields at Wills Eye Hospital, and this is something that I will never forget, and we have reported, I've written on this as well. And what we did was a plaque brachytherapy to this patient, and you can see a small tiny calcification left behind, and this eyes was saved. We also gave systemic chemotherapy for this child. This is a very interesting case where a child has already received 4 sessions of intra-arterial chemotherapy elsewhere, and then because of the recurrence after intra-arterial chemotherapy, this child was referred to me. There was a bit of vitreous hemorrhage, as you can see here. Well, I didn't want to enucleate it because, it is away from the disc. The disc was very well seen. There is no risk to life. So what I thought was, well, I in fact thought probably the IAC was not given right. The dosage would not have been right. The technique would have not been right. So I went ahead giving a systemic chemotherapy. With systemic 6 cycles of systemic chemotherapy, the tumor completely regressed. We were rejoicing. I was so happy. But I realized this is a chemo-resistant tumor. It was resistant to systemic VEC. It was not about the technique. It was not about the drug. It was resistant to VEC as well as intraarterial chemotherapy drugs. And it's a solitary tumor. I still wanted to save the eye, and the parents were insisting. So the final thing that I had in my hand was the ruthenium plaque brachytherapy. Brachytherapy was given, and then finally we could save the eye. So brachytherapy, most of the time I use as a secondary modality of treatment, not as a primary modality of treatment whenever there is a recurrence. This is a similar case where all the treatment has been given, there is a recurrence again, a plaque was given, and we could salvage the eye. So we have to assess clinically whether there is any systemic risk for metastasis and micrometastasis. That is when we take the call on enucleation. You have to always think about parent compliance, whether they're going to come for follow-up, because it's a journey. It's a journey with the parent, the child, and you. And if you think that they will not be able to be part of this journey, compliant, then it's always good to enucleate if it's a bad eye. Rehabilitation is very important. Every parent, when they hear, or you explain that the eyeball is going to take out, when you explain about enucleation, most of the instance they run away. They run away for a time, they come back with orbital retinoblastoma. So the counseling has to be so well, and you have to promise the parent that I'm going to give you an eye which is going to look exactly like the other eye, only you, me, and the baby will know that it's an artificial eye. So rehabilitation is so very important for the quality of life for these children. Now, enucleation is definitely not the end in retinoblastoma. There are certain rules that we follow: minimal manipulation, never, never rupture the globe. Avoid accidental perforation. Long optic nerve stump has to be taken. My rule is less than 15 millimeters. I consider it as suboptimal. I always aim for more than 15 millimeters. And why do we say that it's not the end? Because pathological high-risk features has to be assessed. You just cannot enucleate and then, think that it's the end and give the process and send the patient. You have to call the pathologist, ask for all the high-risk features listed in the pathology report and look for it. If it is present, you have to look for CSF cytology, bone marrow biopsy, check for systemic micrometastasis, and then if pathological risk factors are present, post-enucleation adjuvant chemotherapy has to be given for life salvage. Orbital retinoblastoma is yet another challenging situation. We are coming from intraocular to extraocular now. Usually in advanced retinoblastoma, as I told you, the parents will go missing, lost to follow-up, late diagnosis, improper enucleation technique. There can be intraocular surgeries done in these patients, misdiagnosis, as I told you, vitritis, etc., etc. And this is how usually they present. Mostly it is unilateral presentation, but unfortunately I have seen in my practice with bilateral orbital retinoblastoma, and it's so heavy to my heart when I see these babies coming in. But we do have the intensive multimodal treatment protocol, and this is the survival that we have got. If it is extraocular extension without CSF metastasis or CNS metastasis. When it's CNS metastasis, whatever it is, it's very difficult to salvage the life of these patients. And we have actually got 95% survival in these children. This is pre-treatment. This is how the child is, and this is post-treatment after intensive multimodal treatment protocol with a good quality of life and the child doing well. So thank you so very much for your patient listening. And I would say at this point of time, retinoblastoma is a precise patient-centered holistic approach. Every case is different, and we have so much of treatment armamentarium in our hand. There is always a multimodal treatment approach that we actually, embrace in giving life to these patients, salvaging their eyes, and trying to give sight to these children. Thank you very, very much.
Thank you, ma'am, for taking us through so many challenging cases and the real challenges you have faced in managing such cases. Regarding the genetic testing, I just wanted to ask which patients should we refer for genetic testing, and what is the cost involved actually, and where should we send?
Yeah, so Bijna, the current protocol is genetic testing is not an option. It's actually mandatory. But then in our situation, often the patients cannot afford genetic testing. MedGenome does it. It's around 35,000 for the genetic testing to be done. I also work with a public hospital in Kerala, which is called Malabar Cancer Center. So we have set up a lab where we do it actually free of cost, but that is applicable for the patients from that particular state. But patients from outside state, it is very subsidized. So it's around 15K. I am aware that in Aravind Eye Care System in Madurai, they also provide genetic testing at a very subsidized rate. I think it's around 15K to 18K. So these are the places where, you can find. Yeah, so genetic testing is actually essential at this point. Yeah.
So, can Dr. Bhavna or Dr. Chandana, can you speak about it? Because Dr. Chandana comes from a government hospital background where she must be seeing. And Dr. Bhavna is there at the apex. So, can you throw light into the what are the recent treatment modalities or how you are managing your cases?
Sure. So just a few things, what Dr. Foiruz talked about. So I also came to know many things from her talk. Dr. Debjyoti and Dr. Foiruz, thanks a lot for that elaborate talk on retinoblastoma. While working at the Regional Institute of Ophthalmology, Kolkata, what I felt is that the diagnosis, the treatment, especially the treatment part, the management part is still we are lagging a lot. we have to go a long way. In our government setup, we don't have adequate things. Regarding the diagnosis, I just want to say this thing. Like, I have seen a lot of cases which has been treated as a case of orbital cellulitis for first few days. And the patient then was referred to oculoplastic clinic, like in our clinic. And that time we diagnosed the case. Patient already started getting treatment for orbital cellulitis. And another 2-3 patient I remember diagnosed from the OPD or emergency as a case of hyphema, traumatic hyphema.
Mhm.
And then subsequently it was diagnosed as a case of retinoblastoma.
Mhm.
And another case, I remember 2 cases of uveitis and endophthalmitis. These are the few things. And one patient I remember, the cataract surgery was done already in one of our unit. And then at the end of the cataract surgery, they found that something else is actually the diagnosis, not the cataract. So I think this differential diagnosis of leukocoria, we know these are the things, means for the practical purpose, still I think we have much to know and much to teach the students. That is important.
Yes, ma'am. True.
And regarding the CT and MRI also, in the beginning, when the patient, we are suspecting whether we are dealing with a case of RB or not. This question is to you, CT or MRI, which one is the best for the beginning?
Ma'am, MRI is the diagnostic modality as far as radiological imaging is concerned, for the main reason that I spoke in my first talk, because of the germline mutation. So any child with retinoblastoma exposed to radiotherapy with germline mutation has a high risk of developing osteosarcoma. So we don't do CT. I mean, it's better to avoid CT scan. There are very rare situations, Bhavna can also highlight that, when, we have a diagnostic dilemma, like, it's presenting as an endophthalmitis, very endophytic RB, there is no calcification seen anywhere. At that instance, sometimes we actually order CT, because you can pick up a small calcification, which may not be picked up in an ultrasound if you're not in the right axis. So that is a very rare, scenario that we would do CT. Yeah.
And another thing is that we have done a CT, you are suspecting retinoblastoma. Any other diagnosis can we thought in presence of the calcification?
A diagnosis in the presence of medulloepithelioma.
Yes, I'm
Sometimes
talking about
can
that
have,
only.
yeah,
Yes.
medulloepithelioma can have, but it's usually in this towards the ciliary body, yeah.
Ciliary
So a
body
young
area.
child, yeah, as I told you, ma'am, if it is a young baby, retinoblastoma presents in the posterior pole.
Not
So if
only
it's in the
that,
periphery,
medulloepithelioma will have a clear media, a
yeah.
careful evaluation under
Media,
anesthesia.
you may not clearly see the media. It has already covered the entire vitreous.
Yeah, ma'am.
Entire vitreous
Medulloepithelioma is
cavity.
another one which can have little calcification in there. But as Sir said, there are very characteristic features where you'll have like a sheath of blood vessels which will be growing over the posterior surface of the lens. You can have coloboma of the lens, and it's mostly in the periphery. Whatever you have, not more towards
I
the.
think astrocytic hematoma is also having calcification, which can mimic like retinoblastoma.
Yeah, organized astrocytic hematoma, some calcification, I'm not sure, Dr. Monalisha, but it appears like, grapes. But yeah, I'm not sure about calcification. But again,
Yeah.
another situation,
But mostly
retinoblastoma,
it's
I'll tell you,
nearer to the disc.
nearer to the disc also. Yeah, another thing is thysis bulbi. A
Near
baby,
to the
retinoblastoma can present with thysis bulbi also,
yes.
and in traumatic thysis bulbi also you can find dystrophic calcification. So in a baby presenting with retinoblastoma having a calcification, definitely enucleate, So yeah,
Yeah.
if there is no
When
history,
there is a high suspicion, it's
yeah, enucleate. Yeah.
better to go for enucleation. Yeah.
Correct.
Then subject it to pathology. It's not enucleation that is important. Subject
Yeah.
it to pathology and rule out the retinoblastoma.
Exactly, sir. Exactly. Yeah.
And sometimes also our students, they confuse regarding whether we are dealing with a case of toxocara endophthalmitis or it is retinoblastoma. When there is no chance of vision, I think we should better go for the enucleation.
Yeah.
When you're
Dr. Ajit Babu, sir, you would have, I'm sure, experience, where it is toxocara or toxoplasma, the vitreous is full, and endophthalmitis also. What do you do in those cases? How do you go about? Do you take a biopsy or?
We take a
Just wanted to
biopsy,
ask the
but
same question.
if you have the suspicion of retinoblastoma, by no means, because the risk of spreading is very, very high.
Yeah.
So
diagnosing
what
these
we'll
two
do
things,
is,
diagnosing these two entity.
on the table, we take the aspiration, and if at all it proves to be retinoblastoma, then immediately you go for enucleation.
You send it for frozen.
Otherwise,
cytology.
yeah, otherwise you will treat it as do a vitrectomy and treat it as endophthalmitis.
I think
Both these will be
I
studied.
think Dr. Ajit Babu, what I feel is that would differentiate these two diagnoses, toxocara endof and or toxocara endof, and the IOP is a very crucial thing. I think if it is a case of retinoblastoma, the IOP is usually higher side, but not in a case of endof or this thing.
Yeah, endophthalmitis definitely the IOP will be lower side. But toxocara, it can be both. It can be high, it can be low.
Acha. Usually, what
It is not
we have come across, it
there will
is on
not
the
be
lower
any
side.
hypotony with the toxocara.
Ma'am, but secondary glaucoma in retinoblastoma, there are two causes. One is a large tumor which is pushing the lens and causing an angle closure and causing a IOP. The second cause, the only cause is NVI.
Yeah, neovascularization of
Neovascular iris
angle.
and NV angle, neovascularization of the angle, and then causing it. So obviously, which will not be present in toxocara or endophthalmitis. Yeah.
But in our setup, we usually get this type of cases quite late. So that time the IOP is high, except those cases which the other eye is thiacal eye. That is a different.
It's just not the case in government medical college. Everywhere in India, we kind of have the challenge of getting advanced tumors.
Regarding the management, there are some NGOs, they have come up. Like one is that Can Kit. They are helping the parents they are giving food, they're giving monetary.
Madam, sorry, madam, can I just interrupt? We have one more talk to go. And,
Okay. Sure. Finish it.
Dr. Bigil, can we take the last talk? So
Yes,
after that,
yes.
we can discuss.
So thank you all panelists for such an insightful discussion. So we move on to our third speaker. Sir?
Very nice discussion.
We go to the last speaker.
Yes, we should move on to our third speaker. He is Dr. Debasi Sahu. Actually, Dr. Sonali is not able to join with us. So we have Dr. Debasi Sahu. He is currently working as assistant professor in Department of Pediatric Hemato-Oncology at AIIMS Bhubaneswar. His area of interest are pediatric lymphoma, sarcoma, thalassemia. And he is going to speak to us about management of retinoblastoma in terms of pediatric oncologist. So, Dr. Debasi, over to you.
Thank you for the introduction. Shall I share my slides?
Yes, you can go ahead.
Are my slides visible?
Yes, it is
Yeah,
visible.
make
Make
it.
it
Yes. That.
Visible.
Yeah. So much of the retinoblastoma treatment has been discussed, so it makes my work a bit simple. So I'll talk about the pediatric oncology perspective of retinoblastoma. So this already has been discussed. Retinoblastoma is the most common primary intraocular malignancy of childhood, accounting for 10 to 15% of the cancers during the first year of life. And most of the cases are diagnosed before 5 years, except few cases. And this has been discussed. The incidence of retinoblastoma is significantly higher in lower middle income countries where the socioeconomic status are poor, where hygiene is poor, as compared to the developing nations. And the survival has been discussed. The survival in retinoblastoma exceeds more than 95% in the developed countries. Whereas if you see the data from India, it somewhere between 45 to 65%. And the main reason is the late presentation. Whereas rarely there will be children with extraocular retinoblastoma in developed countries, whereas in India, you see a significant proportion of children with retinoblastoma having extraocular presentation. So now, into what are the goals of therapy when you see a child with retinoblastoma? The first important thing is to preserve life, to preserve the eye, and preserve vision. So these are the common goals of therapy when you see a child with retinoblastoma. Along with this, while maintaining a good quality of life, preventing the late effects, and preventing second malignant neoplasms, as discussed in the cases of heritable retinoblastoma. Now, this is the international staging system of retinoblastoma. So I'll take the help of this slide to discuss the approach towards the disease. So when there is a child with intraocular retinoblastoma, it will be either stage 0 or 1. There we can preserve both the vision of the child, preserve the eye, and preserve the life. Whereas when the child presents late and presents to us in extraocular or orbital stage, it will be stage 2 or 3. There, the vision and globe salvage is not possible, and there the priority is to preserve life. And whereas the child presents with metastatic disease, whereas like 4A or 4B, the intent is to preserve life in stage 4A, whereas in stage 4B, where there is CNS involvement, at most places it will be chiefly palliation, whereas even preserving the life is not possible in most cases. And how we approach the case in intraocular retinoblastoma? It has to be a combination of focal therapy along with systemic chemotherapy, or various permutation and combination of all of this, intraocular or local chemotherapy and radiotherapy. Whereas in extraocular retinoblastoma, a combination of surgery with intensive chemotherapy and radiotherapy will be used. Whereas in stage 4A, where there is bone marrow or bone metastasis, there, along with all those modalities, we take bone marrow transplant to preserve life and to improve the outcomes. Whereas in 4B, still, despite all these intensive multimodal therapies, the outcomes are extremely poor. Now coming to the focal therapy, and there are various modalities like laser photocoagulation, thermotherapy, and cryotherapy. There are various pros and cons of this, and we have to choose the right modality of the focal therapy based on the location and size of the tumor. I'm coming to systemic chemotherapy. It consists of multi-agent chemotherapy every 3 to 4 weekly for chemoreduction. So in intraocular retinoblastoma, it is to enable the focal therapy, or in extraocular to enable enucleation. And the most commonly used regimes are a combination of carboplatin, etoposide, and vincristine. It is the CEV regime that is the most commonly used. That is, and with pretty good efficacy and acceptable toxicity. The other regimes are like high dose CEV that has been increasingly used, particularly in group D and group E retinoblastoma that includes higher dose of carboplatin and etoposide. And there have been approaches like addition of cyclophosphamide, the other drugs like cyclophosphamide or idarubicin, or the emerging topotecan-based chemotherapy. Despite that, CEV regime continues to be the most acceptable and widely used chemotherapy. Now, what are the indications of systemic chemotherapy? So, systemic chemotherapy has to be used in combination with other modalities like intraocular disease group B onwards, and more importantly, in bilateral disease, it has been found that with the advent of systemic chemotherapy, the incidence of trilateral retinoblastoma has significantly come down. And in extraocular retinoblastoma, to enable enucleation of the eye, and of course in metastatic disease. So when you come back to the various stages of retinoblastoma, so in intraocular, it has to be combination of chemotherapy with focal therapy. Whereas in extraocular, it is to enable sterilization of the extraocular disease, and we combine with radiotherapy. And in metastatic disease like 4A, it has to be chemotherapy followed by stem cell transplant and radiotherapy. So in intraocular disease, we use up to 6 cycles of chemotherapy based on the response. Whereas in extraocular, we use up to 12 cycles of chemotherapy. Now there are various trials ongoing whether we can reduce the number of cycles of chemotherapy from 12 to 6 cycles to reduce the morbidity. And whereas in metastatic disease, it is usually followed by stem cell transplant, where you use various regimes like thiotepa and cyclophosphamide, mainly to reduce the CNS relapses. Now, it was the brachytherapy has been touched briefly. Now, plaque brachytherapy is emerging as a very good modality as a means of globe salvage, where the tumor is not responding to the conventional measures, and it is chiefly used in the smaller tumors where it has the primary chemotherapy or other modalities have failed, and it is pretty effective in that for globe salvage in smaller tumors. And I won't go into the details of this. So it has been first the unilateral and non-heritable, preferably the non-heritable groups B and C and D. These are the situations where plaque brachytherapy are being increasingly used. And why this is non-heritable is that the heritable, like it was discussed in the heritable retinoblastoma, there is higher likelihood of secondary malignant neoplasms, particularly osteosarcoma with exposure to radiotherapy. So this is preferably avoided in the heritable retinoblastoma. Now the new kid in the block, not exactly new, but this is being increasingly used, is the intraocular chemotherapy or the ophthalmic artery chemosurgery. It is also called surgery because it is good in very effective in chemo reduction. So the agents which are used are either alone or in combination, like melphalan, carboplatin, and topotecan. So the chemotherapy is directly injected into the ophthalmic artery through intervention radiology. So either as a single agent or 2 drugs or a combination of the 3 drugs. Though there are no prospective trials comparing the intraarterial chemotherapy, but in various case series, the globe salvage rates have been drastically higher, and particularly where the systemic chemotherapy have failed. So so this is the new emerging chemotherapy. However, it is limited by limited availability as well as the cost and as well as expertise. So this can be used either as a primary modality or in those children who have failed the conventional chemotherapy. So it has the advantage of high in local drug levels with lesser systemic side effects. And usually it is when it is used in can be used most often in unilateral disease, but when used in bilateral, it has to be used in combination with systemic chemotherapy as well to prevent development of trilateral retinoblastoma. and in those cases where it has not been controlled with other modalities. Now, actually, the enucleation, the indications for enucleation is a difficult choice, but the definite indications for enucleation are extraocular retinoblastoma, where vision salvage or globe salvage is not possible, or in group E, intraocular disease, where there is no vision. This was the standard of care before, but now it is being with the newer advances of chemotherapy and other local therapy, as well as intraocular chemotherapy. This also is being there have been attempts to reduce the second indication, this indication for enucleation. And the more frequent indication now is the group D or E disease, but there is a resistant or recalcitrant disease or relapsed disease which has failed the other modalities. And this is more practical where adequate follow-up is not possible in presence of difficult to salvage therapy, where may not be able to ensure adequate follow-up for the therapy. This is being increasingly used. However, with the current era, this should be kept at a minimum. So the take-home message, retinoblastoma, the treatment involves multimodal therapy for a successful outcome, and there has to be robust interdepartmental coordination. And the goals of therapy in each child has to be individualized and should be well defined at the start of therapy with regular monitoring and assessment. And vision salvage is highly probable in intraocular disease with the available therapies, and however, it is not possible in extraocular disease. And the timely initiation of the appropriate therapy is crucial for successful outcome. And in addition to that, we have to see not only at the child, but also at the family, like screening of the siblings, appropriate genetic counseling, and monitoring for the late effects and secondary neoplasms. Thank you.
So thank you, Devasis, for that elaborate presentation. So we can take one question anyone has before we can close down, because we are running really late.
So
I want to
just
ask.
one-
I have so many
Sorry.
people have questions.
Anuradha is asking. You should listen to her.
Yeah. Sir, good evening, everyone. So my question to all the teachers who are doing extensive work in retinoblastoma, if a younger kid is present with orbital cellulitis and sometimes they are crying, that parents also doesn't give good history also. So it not to miss or retinoblastoma, not to misdiagnose it, EUA is must, or anything else we can do rather than treating it as general orbital cellulitis and giving antibiotic?
Look at the age, look at the history, treat the
Imaging.
patient for inflammation, get an imaging done.
Go for MRI.
Yeah,
I would say
MRI is best.
go for MRI.
MRI, yes.
MRI is
Let me
best.
tell you.
EA, if they cannot afford MRI, first EA, then MRI.
So because in
most
most of the standalone eye hospital, in-house anesthetics is not available. So doing a
MRI is easy for you.
Imaging
MRI is the first thing to be done, Anuradha. Just not a baby with orbital cellulitis. Any orbital cellulitis, if you have, I think you should get an MRI done, especially.
Fairuj, I just beg to differ, because doing an MRI in a baby is not a very easy task. And that is not available everywhere also. But this type of cases, what I have seen, if you ask the parents the detailed history, they will definitely give you the history of this Bedal ka cat's eye, cat's reflex. They will definitely give you the history. You don't need the MRI to do right at that point. This is my experience.
Ma'am, MRI is important in that. One, obviously, diagnosis, but anything which is that severe can have an optic nerve extension. It can have an intracranial extension. So there you're actually staging the disease.
Yeah, not only just diagnosis, it's extension
it's staging.
of
It's
this thing
staging
is
the
more
disease,
important.
ma'am.
I think we can do that is for diagnosis of RB MRI, I know. But before that, you can
see, it's difficult in a crying baby. It's difficult to do an ultrasound also.
So you can do a B scan, which will give us a clue.
One dose of prednisolone works wonder in the case of this type of cases, this aseptic cellulitis. That you can give, and then you proceed for MRI and everything.
Yeah, I agree with Dr. Chakravarti that steroids to treat the inflammation actually makes a big difference. And it also has a technical importance when you are imaging, that if tissue edema is a lot, then inter-tissue planes get very, fuzzy when you pick them up on imaging. So it's difficult to make out masses. So if the inflammation can be controlled a bit, and then the baby can be sent for imaging, that gives you a better imaging outcome.
Thank you, sir.
And
So
I'll
what
just
about the B scan? What I'm saying? Why
B
cannot we
scan.
can see the calcification?
Yes, you
Not
can.
in all the cases you can get the calcification,
Yes,
right?
yes.
You can
Oh,
do a screening
that's true. But
ultrasound
some
just if you
cases,
Scan
want
is
to.
basic. Yes,
A
true.
screening ultrasound for a very basic gross estimation of whether you can pick up intraocular calcification. If you pick up intraocular calcification, then you are obviously leaning towards the diagnosis of retinoblastoma more.
Right. Agree.
And I'll just take this opportunity to ask a quick question to Feroz and to Dr. Bhavna, both of you. When do you use high dose intravitreal chemotherapy? 100 microgram or more?
So, yeah, high dose topotecan. Off late, there is literature to show the evidence that it works well and there is no toxicity. But to be very honest, we mostly start with standard dose, which we call as 20 to 30 micrograms. And because we can give repeat injections, and every time it's the EUA that guides us, how to continue, how many more, sessions to give, and what dose to give. So if we feel that it is responding well to low dose, we definitely want to stick to low dose. But if we feel that the response is not as good and we want an accelerated response, then we go higher as well. Personally, I've gone up to 60 micrograms, though in the literature people have gone even up to as high as 100 and beyond.
Dr. Devjyoti, I have never given 100. I stick on to 30. My maximum dosage that I've given is 50.
You ask him now where he will give 100.
No, so
Yes.
I have no experience.
We are asking you.
No, I have not given it.
You're asking me, sir? Okay, so I have given a few patients, especially in heavily treated eyes, who have recurrent vitreous seeds after resolution. So when the vitreous seeds have come back, and actually we used to give melphalan and topotecan as a combination, but since melphalan, in our earlier patients, we have seen that melphalan has a lot of retinal toxicity as well as post-injection very severe intraocular inflammation that leads to a lot of synechia, cataracts that develop very quickly. So we have actually completely given up on melphalan. We don't use melphalan anymore unless we are really pushed with our backs to the wall. We try to deal with recurrent disease, and I have done some cases where the seeds have just not responded to 30 microgram or 40 microgram of topotecan at all. So I scaled it up to 100. And the first report, I think, was from Dr. David Abramson, who reported 90 microgram. And then in our institute, we have had several cases with ERG recording of retinal toxicity post-injection and evidence that topotecan is in fact very safe even at 100 microgram. And recently, I trained with Dr. Francis Munier for a while at Lausanne in 2022. And recently, in one of my conversations with him, he told me that he has gone up to 150 micrograms. So people are doing 150 micrograms now.
That's
So
great.
I was visiting
People are doing
Wilsai
super high
Oncology.
dose.
Yeah,
Super
I
high
was
dose.
visiting Wilsai Oncology in January, Dr. Devjyoti. So Carol gave her first patient 150 microgram, her first patient. So they also don't give it too often, but only when, yeah. So I have never gone 100. My maximum
So
is
the max I have gone is 100. And I also talked to Paula Shakovich. I don't know if you have heard of
Yes.
her name. You must have.
Yes.
She is the one who's done a lot of work on animal models on intravitreal dosage. And she told me outright that slowly you will find that 150 micrograms is a very safe level. So I don't know. I mean, I always question myself that should we start giving 100 microgram routinely, but when the response is coming at 30 microgram, I don't feel that 100 microgram is really justified as a routine practice. Would you
Absolutely.
agree?
Yeah. Absolutely. Absolutely. Yeah.
That's totally correct. I mean, we want to keep the dose as minimum as possible as long as the desired response is coming.
Yeah.
Thanks. I reassure myself that I am still on the right track as far as my approach is concerned. Thank you.
Thank you. Thank you.
Thank you. Thank you, everyone.
Thank you, everyone.
Are we done?
Yeah.
Okay.
So, any
Much.
more questions?
No more.
Since Dr. Santosh is not available, so I thank you all.
Excuse me, I wanted to ask one thing.
Prajita
you
finally
can.
opened her mouth.
Yeah. Actually,
you
in the OPD, we found one patient severely is crying baby with painful inflamed eye. So there was a dilemma of orbital cellulitis. We also thought of retinoblastoma. But by history, patient told the patient had already been enucleated. So it was a case of orbital recurrence. So what is the will be the approach to such cases? How we can differentiate it from other entities like
Okay.
No, what was the pathological diagnosis, Prajita?
Enucleation.
No, enucleation, but it should be subjected for
It's retinoblastoma proven, right?
histopathology.
It was proven, but after
Because
some time,
there
the
is a
patient told
danger
that
of recurrence. That is the most danger.
It's the orbital recurrence. So, Apachita, it is
If
an
it
orbital artery.
recurs,
Yeah, which is called
that can be very, very dangerous actually, because the stump of the optic nerve directly will have a intracerebral extension of the recurrence.
So, Dr. Aparjita, again, imaging has to be done, as Sir said, because it's an orbital recurrence. We call it a secondary orbital retinoblastoma, where enucleation is done and the tumor has recurred in the orbit. So, first and foremost, we need to know whether there is any optic nerve involvement, apical involvement, intracranial extension. Then you have to go ahead doing the bone marrow biopsy and the CSF cytology to stage it. As Dr. Debashis said, if it is CNS metastasis, the prognosis is very, very poor. Then it becomes a palliative treatment. But then if the CSF cytology is negative, even if it's bone marrow positive, then we go in for the protocol of orbital retinoblastoma. Bhavna is here. So we, as ocular oncologist, we are very comfortable with the escalated dose of VEC protocol in orbital retinoblastoma. But then there is an ARET protocol also. So we would go for intensive multimodal treatment protocol where chemotherapy is given, it is shrunken, then we radiate and we give 12 cycles of high dose chemotherapy. But if there is systemic metastasis, then it's a different ball game. Then we give a different protocol. Yeah. So.
Yeah, so just to add to what Feru said, if there's systemic metastasis, if it's a bone marrow hematogenous metastasis, then we go for autologous stem cell transplantation at our center. If it is CNS metastasis, mostly it is palliative care only.
Yeah.
So thank you, because we don't have much time, but we also wanted to talk about AI, what is the role of artificial intelligence also, which is coming up. Then talking also about the molecular targeted therapies now, which is coming up, that could have added completely. But Dr. Bhavna, if you can put one word before we close it, that will be also fine, and we can complete the entire session.
So at the outset, first of all, my gratitude to you for taking up this topic in the seminar. Retinoblastoma is, a topic which is so close to my heart. And I'm really delighted that, so much learning has happened in this seminar, especially for the residents and the PGs, starting from all the differential diagnosis and the approach to a child with leukocoria to, all the latest globe salvage management that we have that Feru so nicely, illustrated. So all of this is very important to know, and then also, to highlight that how multidisciplinary approach, as ophthalmologists, we really need to be a part of a multidisciplinary team to be able to do justice to these patients. You require a pediatric oncologist, a radiation oncologist. For plaque brachytherapy, we need a medical physicist. Then for intraarterial chemotherapy, we need an interventional neuroradiologist. And then, not to talk of, the important role of genetics and even an ocularist for a good prosthetic fitting. So, so many specialities are involved in the care of retinoblastoma. And, India really needs these kind of, more and more centers, like as Dr. Chakravarti ma'am said, that, in the government setup, especially, a lot of facilities are lacking and infrastructure needs to be built up. So we really need to, have a pan-India kind of initiative where, more and more centers and multidisciplinary teams take up this challenge of, treating retinoblastoma cases rather than, referring them to higher centers all the time. So a lot has been
All
done
aims
and
should
a
have
lot.
all the facilities. Wow.
Absolutely, sir. Absolutely. I
And
mean, we
RIOs
feel really
also,
All
sorry,
Nurali.
aims branches should
when
have all the facilities.
yes, sir.
Chandra
We feel
ma'am, yeah.
really sorry that, children from different AIMS in the country are being referred to AIMS Delhi for retinoblastoma treatment. I think that must stop immediately. All tertiary care centers should develop their, infrastructure and facilities to
Yes,
treat
yes, yes.
retinoblastoma. And it's, sad for the children and the families to be traveling such long distances and endure such long treatments, in a, another place. So a lot needs to be done. And, even at the level of community, where we talk about extraocular retinoblastoma, why are we getting them at this late stage, so advanced, unlike the West? So a lot of work has to be done at the level of community to sensitize people about the early signs. Like, so Dr. Devjyoti so nicely, he showed us, that, and what was so important, what he highlighted was that for us in India, though we can say that all that is white is not retinoblastoma, but we should work on exclusion. We should presume that it is retinoblastoma and then, work from there. So, always keep that, high index of suspicion in your mind, even though you may have different types of presentations, whether it's orbital cellulitis, phthisis, secondary glaucoma, name it, and it can present like retinoblastoma. So always having that high clinical index of suspicion. I always tell my residents on the rounds, we've had cases where trabeculectomy has been done outside, thinking that it was a case of a, a ophthalmic eye, where it was actually harboring a retinoblastoma. So here, you're just like kind of playing with the life of the child, your ignorance. So we can really go a long way, in promoting awareness, in teaching our residents and all these things. And I'm really grateful to everyone
Only
over
that
here.
complete eye examination is grossly lacking in our country.
Absolutely,
I'm
sir.
sorry to say that.
Absolutely. Even a basic ultrasound, is not done in a ophthalmic eye, which is why they miss, Otherwise, there's such a big mass sitting over there. Nobody can miss it, But even a basic ultrasound examination is not done and the child is subjected to trabeculectomy. I think that is totally unacceptable. So we need a lot of work to do, but it's really nice and heartening to see that, everyone is talking about it and doing such good work, whether in the private sector or in the public sector. We have NGOs helping us. So, I think that the future is bright. Thank you very much.
Thank you.
Thank you all speakers, faculties, moderators, and participants. And also I should thank the entire who has supported for this program. And we had a very lively discussion, very interactive discussion. And I hope everyone has benefited from this and hope to see again in some of the meetings and conferences. Until the next series we have.
Anyhow,
Thank you
AWS
all.
we all meet, no? AWS.
Yes.
AWS
So
we are
AOS
meeting.
is so vast.
It is not
AOS
far
is so
away.
And Dr. Sucheta, being the Chairman Scientific Committee of OSOS, thank you so much for choosing retinoblastoma as the first topic of your series of webinar. You have given so much of importance to this cancer, as Bhavana said, because it really, really needs awareness and attention. More than
100%.
learning about the disease, I think you have spread the awareness of the disease to everyone. And I really, really appreciate. Thank you so much, the entire team, OSOS team. Thank you.
I just
Thank
take
you.
this opportunity to quickly mention that WHO in its GICC initiative, which is the Global Initiative for Childhood Cancer, lists retinoblastoma as the 5th most common childhood cancer. So my request to all of you, please spread awareness of early detection as much as you can by whatever means possible at your disposal.
Yes.
Thank you. Thank you very much.
Thank you.
Right.
Thank you so much.
Can we say
Thank
good
you.
night?
And
Good night.
yeah, good night.
Good
Can we
night.